Welcome to Grand Rounds. I'm Melissa Arbuckle. I'm the Vice Chair for Education, and I have the privilege of introducing today's speaker. My one announcement is for next week. Our Grand Rounds will be a clinical Grand Round, so that will be for clinical staff only. It will be one of our own chief residents, Blair Uniacke, who's going to be talking about a case, and her discussants will be Dr. Joanna Steinglass and Dr. Blair Simpson, so please join us for that. This week, I'm very pleased to introduce Dr. Myla Harrison. She's Assistant Commissioner for the Bureau of Mental Health and the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene. The Bureau is responsible for a budget of over $200 million for mental health services ranging from supportive housing to care monitoring and rehabilitative programs. Prior to this position, she was Medical Director of the Bureau of Children, Youth, and Families within the Division of Mental Hygiene. She's a board certified in child and adolescent psychiatry and general psychiatry and is also a trained pediatrician. She received her medical degree from Downstate Medical Center in Brooklyn and then completed her residency training in the triple board program, which is on pediatrics, general psychiatry, and child and adolescent psychiatry at the Mount Sinai Hospital. She then received her master's in public health degree in healthcare management from Columbia University's Mailman School of Public Health, where she is currently an instructor and teaches mental health policy course. Today, she's going to be talking about mental health services in New York City, new initiatives, and critical services. Please join me in welcoming Dr. Harrison.
Great, thank you for that introduction. Thank you for inviting me to your Grand Rounds. I think this will probably be somewhat different than your typical Grand Rounds. I'm not going to be quoting a whole lot of research, although I will show you what we do in New York City when it comes to research and studies and information. Everything is very New York City-centric in today's conversation, and also somewhat adult-focused as well. So, this is me. You heard about me. What we're going to talk about today is epidemiology in New York City, the latest numbers that we have, which are all publicly available, so I will let you know how to get them if you want to see them yourselves. We're going to spend a lot of time talking about the new initiatives that are going on in New York City. There are a lot of them. They are around mental health, and there's a number that I am responsible for, so I'm going to talk in most depth about those sorts of programs and projects that are happening. And then what I call here critical services are the services that I'm responsible for at the New York City Department of Health and Mental Hygiene, just so folks understand the spectrum of work that goes on within the city's health department just from the mental health perspective. So, epidemiology. This is the New York City vital signs. I don't expect you to read it from up there. I'm going to drill down into some of the numbers that we've been looking at. This vital signs is from June 2015, so it's already a bit old, but we take information that we have access to, whether it's our own city's community health surveys or hospital level Sparks data or Medicaid data. We will take that information and we will put it out publicly so that we can help make public health and policy decisions around data and information. So this vital signs is about serious mental illness among New York City adults. What we do every year in New York City is something called a community health survey. Community health survey goes out to about 9,000 New Yorkers every year and asks all sorts of health-related questions, and we have mental health and substance use questions on that as well. It's an adult-focused survey, and every year we then look at what we're doing, how the trends are going. In 2012, we were lucky enough to have some additional resources, and we did an additional survey called the Community Mental Health Survey, where we focused in on people who had already said yes to a number of questions and asked them some additional information about their mental health. And so just to show you an example, I said about 8,000 people do the community health survey. In 2012, it was 8,534. And out of those folks, we looked at who met criteria on the Kessler-6, the K6, measure of serious psychological distress. and if anyone had endorsed lifetime diagnoses of bipolar, psychosis, schizophrenia, major depressive disorder. If they had a certain score on the K6 and had endorsed any of these symptoms or these disorders, they were then eligible to take the community mental health survey. And then we got 846 people saying meeting that criteria with a 70% response rate, and then another 590 agreed to participate. We got 583 people saying, responding to those questions. So it's an overall 69% response rate. So what did we find? Oh, again, this is just how we then came to define serious mental illness. So there was an algorithm that took into account the measures on the Kessler-6, the scores, took into account the HUDAS, a functional impairment. That's the World Health Organization Disability Assessment Scale. So the folks who responded to the question, the 500 or so folks, also filled out a disability assessment. And then there's an adjustment for age. And SAMHSA, the Substance Abuse Mental Health Services Administration, had put together an algorithm of how to get from those sorts of scores to a definition of serious mental illness for a 12-month period of time. So we used their algorithm, and what we found overall is 3.8% of New Yorkers meet criteria for serious mental illness over a 12-month period of time. So 3.8% is the New York City number. And if you look at this graph, you can see broken down by age, the percent is higher in the 45 to 64-year-old population. It's pretty equal for men and women, but again, it's higher for the lowest income people, by quite a bit, 5% compared to 2% of the highest income people. So there's a disparity of folks who are endorsing serious mental illness. If you look at the same group of folks now who have they tell us they have serious mental illness, they're meeting all of the criteria, and we find out in the past year where they're getting treatment or if they're getting treatment for mental health. Here's the shocker, not so shocking, but still quite surprising. 39% of people with serious mental illness have had no medication or counseling in the past 12 months. So there are, a significant number of people getting connected, are connected to care, but there's still a significant number of people, 40%, 4 out of 10 people, who are not getting counseling or treatment. That translates to about 90,000 New Yorkers not getting treatment. So when I said about 3.8% of the population meets criteria for serious mental illness, that translates to about 239,000 New Yorkers. So that's about the total. That was for the year 2012. But again, 40% or about 90,000 not getting treatment. So we do see about 15% saying they're getting counseling only, 14% medication only, and 30% with a combined medication and counseling. There is a small 1% treatment category. They're telling us something, but we just didn't have enough information, but they are in treatment. So utilization of services for those folks with serious mental illness. Who did they see? Which I kind of told you, this percent in counseling, this percent getting meds. So out of, if you just go back, you can see that counseling and meds, or counseling and medication and counseling add up to about 45%. So about the 45% of New Yorkers with serious mental illness who got counseling, 69% saw a psychiatrist, 17% saw a nurse, and 70% saw some other type of provider, a counselor, a psychologist, a social worker, who gave them their medications. So again, about 45% of the people with serious mental illness who say they're taking medications, 77% are getting it from a psychiatrist, 47% are getting them from a non-psychiatrist. So it's a pretty big number. 5% from a psychiatric nurse practitioner. And then who's more likely to be untreated? So the 18 to 24-year-old group, that transition-aged youth group, They're endorsing SMI, serious mental illness. 84% are untreated. So there's a big gap. 31% of the 45 to 64-year-olds are untreated. So you can see the difference between, where there's a real big disparity. Also, the people who are foreign-born, 52% of them are untreated compared to US-born at 28%. So again, some significant disparities. So what about connection to insurance? This is an interesting topic, given the timeliness of our politics right now. Who is more likely to be treated? So the blue bar is people with serious mental illness who got treatment. The gray bar is people with serious mental illness who did not get treatment. It's missing a word here. So if you had serious mental illness and were on Medicaid, so 52% of people with serious mental illness on Medicaid are getting treatment. So the disparity, again, you might have serious mental illness on Medicaid, not getting treatment. So more people with serious mental illness getting treatment on Medicaid, uninsured, not getting treatment by quite a bit. So again, some more significant disparities. So if we can get more people onto Medicaid, we'd have a better time probably getting them to treatment. How about their physical health care? Again, we're still talking about the population with serious mental illness. So the blue bar are people with serious mental illness. The dark blue bar, I should say. The light blue bar are people without serious mental illness. If you have serious mental illness, this is percent, 43% not getting medical care in the past year, compared to 20% without serious mental illness. So again, another big disparity. Also, if you have serious mental illness, you are more likely to have fair or poor health. This is by self-report. I report my health isn't good. And then even more troubling are the connections to chronic physical problems or unhealthy behaviors. So again, the darker blue bar is serious mental illness. The lighter blue bar, people without serious mental illness. So whether it's hypertension, high cholesterol, more than 2 chronic diseases, asthma, you are sometimes more than twice as likely in those cases to have serious mental illness and those chronic conditions. Here's the one that we have to do something more about, the current smokers. So the population without serious mental illness, 15% of the New York population is smoking. So that's, low numbers, low percentages. But 44% of New Yorkers with serious mental illness are current smokers. That's almost 3 times the amount. That's something we can do something about, right? If we're thinking clinical prescribers. So what kills people with psychiatric disorders? Smoking, hypertension, high cholesterol, they're all related. Hypertension, cholesterol related to cigarettes. So this is a preventable problem, and here's something we can do about it. So we all know that people die earlier when they have serious mental illness, whether it's 25 years or 7 to 10 years, depending on where you're looking, it's still many years, and we can do something. So, they're also not eating as healthily, and they're less engaged in physical activity. But the smoking is within our control. So that was all just from the vital signs. So I just wanted to share with you some of that data. We also put out what are called EPI data briefs. This one came out in June. This one is on adult psychiatric hospitalizations in New York City. I know you can't quite see this from the back of the room, but what this is a map of is looking at the rates of psychiatric hospitalizations for adults where the larger circles, the larger circles, higher rates compared to neighborhood poverty, where the darker blue are the highest poverty areas in New York City. So you get a visual of where, and the hospitalization rates are by residence. So it's not where they're hospitalized, it's where they come from when they're hospitalized. And so you can see in the higher poverty, not always, but certainly clumped in the higher poverty areas, Upper Manhattan and the South Bronx and Central Brooklyn have the highest rates, have some of the highest rates of psychiatric hospitalization for adults. East Harlem, which is up here, has the #1 highest rate of psychiatric hospitalizations. Your neighborhood around here is not the highest. It's like 37th, which is interesting. But again, something we perhaps can do something about and think about. So also from hospitalization data, and the hospitalization data comes from SPARCS data, which is hospital level data. We can look at readmission rates, which is something a lot of hospitals are looking at and a lot of the DISRIP PPSs are looking at and thinking about. So if we looked from our New York City data at the rate of readmission for 30 days, the average is about 13%. And if it's 90 days, it's about 22% across the New York City programs. And for the New York City hospitals, the highest rates of 90-day readmission are for diagnoses such as schizophrenia and bipolar disorder, which account for most of them, but also major depressive disorder. Another Epi data brief, this is our most recent one from September, is about suicides. And you probably all followed the national suicide data that came out around that same time, which showed, you can kind of see it here, which this, I don't have another graph of this, so I'm just going to show it to you on here. This is the US rate overall, that sort of top blue line, going from 2000 to 2014, so the US rates are going up. Our New York City rate is this green line. It's also going up, and I'm going to drill down a little more in the next couple of slides. You can see that the New York City rate for males is not really going up that much, but the New York City female rate is going up, which is also a trend nationally. And I'm going to show you a couple more slides on suicide rates because it's pretty troubling. So again, if you compare suicide rates in New York City from the year 2000 to the year 2014, we see some drastic differences. These are race ethnicity. So this bar is white. I don't know if you can see from the back of the room. Hispanic, Black, and then Asian/Pacific Islander. So the rates for the Asian populations have jumped quite a bit, and the rates for the white population has jumped quite a bit. That's rate per 100,000. If you also break this down by age and by sex, so just to show what we're doing here, we have 2,000 compared to 2014 for males and 2,000 compared to 2014 for females. It's a little hard to read this graph. So again, each of the blue bars are comparing 2000 to 2014. Each of the green bars are comparing 2000 to 2014 for females versus males. So what you see here, again, is in every single age category, the rates for women, girls and women are going up. The girls is pretty troubling. So these are 5 to 17-year-old girls going from barely noticeable, it really used to be like 4 a year, to much more than that. And the other worrisome finding, and this was, I think also the same nationally, is the rates for the men in the middle-aged going up, 45 to 64, but also going up in the 25 to 44 group. If you look at the causes, the methods of suicide from 2000 to 2014, again broken down by males and females. Here's the females on the top, the males on the bottom. These are somewhat hard to distinguish the colors, but let me just show. Firearms are here. not surprising, very low in the women. Jumping from a high place is this next blue that did go down in New York City, jumping from a high place. Jumping or lying in front of objects. There's a pretty large other category, poisoning, and then the last one is hanging, strangulations, and suffocations. Those have gone up quite a bit in New York City. Now, New York City data differs from national data. National data, about half of the suicides are from firearms, not the case here in New York City. And we do have the #1 cause type of suicide, hanging, strangulations, and suffocations. Again, it's gone up from 2000 to 2014. Just make sure that I don't leave out anything important. Yeah, and it's sort of not surprising, the jumping from a high place is a New York City phenomenon, 8 times the country. So we have high places, unfortunately, for people to jump from. But when you see these sorts of causes and where we have problems, this is where you can think about what can you do about it. And sometimes, if it's hanging, strangulations, and suffocations, it's not necessarily the kind of public health response where you can do easy prevention, right? If we had more sort of jumping or lying in front of moving objects, so that's jumping off train platforms, those kinds of things. If we had higher rates of that or increasing rates of that, you might say, well, New York City should do something on all the subways the way they do in Japan, right, where there's a second door that only opens once the train pulls in, so you can't jump off the platform. Those are public health types of interventions you can think about, which gets a little more challenging when you get at the hangings and strangulations from a public health perspective, or from a public place intervention perspective, I should say. So I'm going to move us from epidemiology to new initiatives. So we have been fortunate in New York City to have a mayor and his wife that for the first time ever have cared about mental health. They have cared so much that they have put millions of dollars to mental health promotion and prevention. And a number of the new initiatives in the city, so you can see, here's our first lady, here's her children, here's her husband, here's a deputy mayor, here's a commissioner of the mayor's office of criminal justice. Lots of press around something called Thrive NYC. Thrive NYC, I'm going to show you one more slide, looks like this in paper form. It is available online that you can look at if you have not read, but we call it the roadmap to mental health. And what Thrive NYC does is helps us take a more comprehensive look at the way we think about mental health and promotion so that we can not only take care of those folks at the serious mental illness end of the spectrum, which I kind of started out talking with you about, but also prevent the problems from existing in the first place. What can we do earlier on? What can we do to offer parents support for kids so the kids then don't end up having more serious problems or growing up to have more serious problems? What can we do about preventing trauma? What can we offer in our senior citizen centers? What can we offer in our homeless shelters? So lots of folks were involved in writing Thrive NYC. There was research on how other cities had done it, cities like London. There were lots of meetings that we held at the health department and held in the community to get input on what should go into this plan, what were the most important things to include, how do we think about doing this work differently, how do we think about this from a public health perspective. And we came up with 6 guiding principles, and all of the projects, there are 54 initiatives in all, fit under these 6 guiding principles. So just to give you an example, change the culture has to do with doing something about the mental health stigma. What can we do so that mental illness isn't as stigmatizing as it's been? How do we put things in place to truly change the culture? Reduce stigma, spread information in a positive way with positive messages. Acting early, I kind of alluded to doing things not only at earlier ages, although earlier ages is important, but earlier on in a disease process before it gets to the point where it's so severe. Closing treatment gaps is making sure there are services where people live and want to get their services, which may also be in their primary healthcare setting, for instance. Partnering with communities is really bringing the communities on board with this work so that they are thinking about the resiliency and the strengthening that they need to promote mental health. Using data better is actually taking data, making sure it's out there and available and folks can use it. And then positioning government to lead so that, we're really able to make some changes and charges going forward. These statistics are in the Thrive NYC book that I showed you. I'm not going to really go into them except to say if you look at the New York City numbers for depression alone, you could fill 12 Yankee stadiums with people who have lifetime depression diagnoses just from New York City. I think the other really important ones, I'm not talking so much about the kids today, but we have surveys that survey the public high school students in New York City, and we know that 8% of the public high school students report attempting suicide. So, right, I showed you those suicide rates. So this is a significant problem. And if you took some of the kids' issues and put them in numbers, 73,000 reporting sad or hopeless in any month. Other things, substance use, we've got lots of deaths from alcohol-related causes, 1,800. And then this one is getting a lot of news now, the unintentional drug overdose, the opioid overdose epidemic, where it is still unfortunately the case and growing that we have more deaths from opioid overdoses than from motor vehicle accidents. So clearly something we need to get on top of. So Thrive is cross-city agencies. This is just a list of probably almost all the agencies except the health department. We don't have our logo up here, but it should be, that are working on Thrive initiatives. So the police department's involved, HRA is involved, Administration for Children's Services are involved. So lots of other agencies. Some of them have their own initiatives and projects, and some of them working with us. So select initiatives that I'm going to touch on some of these today. Something called NYC Safe. A lot of these, oops, I keep hitting the wrong button. A lot of these are within my bureau. I'm going to touch on probably 4 out of the 6 of these initiatives today, and I'm happy to talk more about them if folks want to know after. NYC Well is what we used to call LifeNet. Anyone know LifeNet? LifeNet sounds familiar. So LifeNet has been not just rebranded, but reprocured, meaning we had to go find the best agency to do it. It happens to be the same agency that was doing LifeNet. And we added services to what LifeNet could do. So LifeNet was an information and referral line and a suicide prevention line. And we've turned it into more of air traffic controller site as well, so that if somebody calls into NYC Well and they want help connecting to the mental health provider, the person will stay on the line and help them do that. If they give permission to get called back, the person will call them back a day or so later and say, how did it go? Did you get your appointment? What's happening? If they want short-term counseling on the phone, there are therapists to offer short-term telephonic types of counseling. So those were added. The other really critical pieces that were added: peer support on the phone. We had a small peer support service that was separate from LifeNet, that was through a parachute project we had. And peer support's a critical component of what lots of folks need, particularly about connecting and engaging to care. So we added peer support to that as well. We also added the option of texting and chatting. So you can text 24/7. You can chat online 24/7. Those are actually, not surprising, being used a lot. And we've got to figure out how to do that well. There are not that many call centers, contact centers around the country that are doing 24-hour texting and chats. They kind of limit it because they know it's those wee hours in the morning that people are using it. But that's when we want to make sure we've got somebody at the other end of that line phone for them. So if you want to contact NYC Well, it's 888 NYC Well. And you can text Well to this number, 65173, and you can chat at nyc.gov/NYC Well. So there's a number of ways to get help for your patients. You can be a clinician and get help as well. If you need to make a mobile crisis referral and you don't have easy access to a mobile crisis team, that's how you do it. You call NYC Well. So since we launched at the end of October we kept the state funding in this model, and with NYC Well, through Thrive, lots of additional city resources came along. So it almost tripled the program budget with the city resources. Mental Health Service Corps is the largest initiative of the Thrive NYC roadmap. It is probably one of the most ambitious initiatives as well. The purpose of the Mental Health Service Corps is to make sure there are mental health resources in places where people go for their primary care, for the most part, as well as additional resources in behavioral health settings. So this initiative, when fully operational, will be a $50 million a year initiative when fully operational. We are putting early career mental health counselors in primary care setting to do integrated behavioral health primary care using the collaborative care model. And we are also putting them in, 1/3 of them in behavioral health settings as a way to offset where there might be waiting lists, or where there are neighborhoods that have highest needs, or where there are language needs where we have core members who speak that language. This program is encouraging early career social workers to earn their clinical licensure, so they will be encouraged to continue to work in mental health services. And it also, so that's one side of it, we're making sure they're getting their clinical hours, and then the other side is making sure the people in the community get their needs met. So if I'm going to primary care, if this primary care practice has a Mental Health Service Corps member, then the goal is they'll be doing screening for depression, anxiety, substance use, and alcohol disorders, and intervening and treating to measurement-based treatment to target, and using that model. The Mental Health Service Corps has supervisors and psychiatrists that come along with the program, so the site doesn't have to offer it themselves. So it's a real attempt to try to innovate and try to do things differently. So in In our first year, which started in July, we've placed over 100 clinicians so far in primary care, substance use, and mental health sites. And we are in the midst of recruiting sites and soon clinicians for year 2. So what I didn't remember to say is the early career mental health clinicians serve 3-year terms. So they will be placed at a site for 3 years. And we're starting with 100. Next year, we're adding 100 or so more clinicians and sites. And the 3rd year, we're adding another 100 or so clinicians and sites. That will be a fully operational year. And then that first year class will graduate and we'll add another class at that point. That's the plan with this program. Quite ambitious. We're tracking where the sites are, putting them in high-need neighborhoods. We're tracking the hours that the clinicians are earning to make sure that they're actually, really adding value and that they're getting their clinical licensure as well. So quite ambitious. We're now hoping to do more focused work with the New York City PPSs so that we can think about the networks that the hospitals have with their PPS providers and really expand the ability to do integrated care. Every single performing provider system of New York City's district programs has said they were doing integrated mental health and behavioral mental health and primary care, and a number of them could use some assistance in getting that really going, and this is a way to do that. Another program we have that's in the Thrive roadmap is called NYC Safe. NYC Safe is a way to support people with mental illness who also have criminal justice histories and histories of violence. We know that there are folks in this category who traditionally do not engage well in our mental health services. Our services don't meet their needs, and in fact may be more punitive to some degrees than they should be. And we know that there are people who have been disconnected from care and then who've gone on to hurt somebody. This came to the mayor's attention. The mayor wanted to do something about it, and we have put some new resources and services in place as a way to meet some of the needs of the folks who really have trouble engaging in care. Perhaps they're homeless, they've been traumatized, and folks aren't recognizing all of that. So I'm going to talk a little bit more in depth on a new program called Intensive Mobile Treatment. I'm going to touch on, and we have 3 new intensive mobile treatment teams in New York City. They're pretty small programs, but they're doing an amazing job. I'm going to touch on 5 new forensic assertive community treatment teams we put in place. We've enhanced almost all of the ACT programs with a substance use specialist. And we put a new team in place with clinicians working with the police department. I'm going to go into these in a little bit more. And we've also added some additional oversight on our end to make sure that, again, we have some more traffic control around folks who need these sorts of levels of care. So if somebody needs a high level service like an ACT team or an IMT team, an intensive mobile treatment team, as best as we can, either we at the health department know where they are, or the provider who's been assigned that person is accountable to know where they are so that they don't go missing. As best as we can help connect to care and meet their needs. And so engagement's pretty critical. We're also evaluating our existing ACT programs as part of NYC Safe. So I mentioned the 3 intensive mobile treatment teams. They're each serving only 25 people at a time. And they've got 7.5 full-time equivalent staff that are clinically or case monitoring focused to take care of those 25 people. So it's a really intensive team, and they will go wherever that person is. They'll meet them at Rikers, they'll find them on the street. Many of them are homeless. We have also put 5 new forensic ACT teams out in the community where there's more of a focus on criminal justice involvement. There was one forensic act team in New York City that was one that a judge had to kind of direct you to. These are not criminally directed, so it's not an alternative to incarceration as a program, but if somebody has significant forensic involvement and needs the level of care of an assertive community treatment team, we've expanded that capacity. So these IMT programs, where we're serving only 25 clients, we really had to write a new model. We kind of had to say, well, what's not working and what do we need to do better to meet the needs of somebody who is violent, homeless, and has mental illness, and where the system has failed them. The system's good at failing folks, that we do that really well. Figuring out how to not fail folks is a harder task. And we put some principles together where we said, access, kind of said that already. We will find you wherever you are, and even if you don't want us, we're gonna try to figure out what you do need and meet your needs. That also means we're engaging you. There's a small budget for wraparound kinds of services and supports. If you need a telephone, we will get you a telephone. If you need shoes and a winter jacket, we will get that for you. Again, what do you as a participant in this program need, as opposed to, we know what you need and here it is. It's a once a week or twice a week mental health treatment model. That's not working. So that's where the continuity of care comes in. These folks are followed. They're seen as many times a week as they need to be seen. They don't have to come to a site. The folks will come to them. There's a lot of attention to their criminogenic and violence risk. So there's a lot of tools that we're using to pay attention to that and to target that as well. And we're really thinking about the person's sense of their own agency. What do they need and want? And I mentioned the forensic act teams already. We've put one in every borough except Staten Island, and they are all operating and taking new clients. And for those of you who may not know, act teams serve 68 people at any given time. These teams are still adding more participants to their teams right now. We're also evaluating our ACT programs right now. There are 44 ACT teams in New York City, including some of the state-operated ones. And it's what I've been hearing since I've been in this job now about 2 years is the ACT teams are overwhelmed and the patients are worse. And perhaps that's so, but let's look and see what we can find. Let's see where there are strengths. Let's see what's working well. When we added a substance use specialist through the Thrive Initiative to each of the current ACT teams, it's because we heard about co-occurring disorders and perhaps not enough resources to do that. So New York City, so there's an ACT team model for New York State. We follow that model, except we've now diverged because in New York City we added a substance use specialist to every team. And we're now looking to see if that's making a difference. This ACT evaluation isn't about the substance use specialist because the timing didn't work for that. It really is just about your ACT teams and how they're operating. We're talking to consumers on the ACT teams, we're talking to staff on the ACT teams, we're talking to the family members of consumers, and really putting together a sense of what the concerns are and again, what's working well that we can focus on and where we need to make some improvements. Also, again, as I mentioned a few minutes ago, as part of NYC Safe, we did something that other cities and localities have done that we had not done in New York before, which is called a co-response team. It's teaming up clinicians, social workers, with police officers, and going into the community and meeting people on the street who have mental illness and some maybe higher level of violence or worry. And it's a pretty small group of folks, so it's not operating throughout New York City. It's not operating at night or on the weekends at this point, but they are intervening. They can go into the shelters where there are folks who have needs. They can meet someone on the street, and they're really assessing the situation and coming up with sort of where to refer somebody to, for the most part. They've seen hundreds of people since operating, not quite a year now. And then the next part of my presentation is, as I said, what I call critical services, which are not what you might think of as critical services. It's really what my bureau is responsible for. And so in New York City, in the local government unit, which is kind of where we operate, we've got responsibility for everything from program development. So we're putting a new program out there. So IMT, intensive mobile treatment teams, co-response teams, new programs, we develop them and have to figure out how to get whatever funding we have to a provider to do the work, which is what we call procurement. We're involved in planning. We have a statutory responsibility to let the State Office of Mental Health know what our planning needs are in New York City, and that's every year we have to do that. We also have a couple of $100 million of programs with contracts that we're responsible for overseeing. So it's a contractual and a program oversight, monitoring and evaluation responsibility. The data I presented to you in the earlier part of this conversation is what we call surveillance, and then we also do research. So I mentioned our over $200 million budget with over 340 contracts and working with over 120 community-based organizations. So it's pretty large, and yet it's not meeting the needs. So again, it's pretty large, but not quite enough. What you're not seeing here, when I talk about what I have responsibility for, are the state-operated programs. So you don't see that in my talk because I don't have that responsibility. My office is broken down into a number of different offices where we've got AOT, supportive housing, we've got treatment, we've got care coordination and the single point of access, rehabilitation services, NYC START, our first episode psychosis program, and research and evaluation. I'm going to touch quickly on these. To me, this is what I do every day, but it's not the most interesting part of a conversation. But I'm going to show you I'm going to make it interesting anyway. AOT, which you should all know, people call it Kendra's Law. It is the court-ordered outpatient treatment mandate for those people who meet criteria. This is the interesting part. So AOT active cases, this is just from 2012 to the third quarter of 2016. I didn't update it yet for the end of the year. But this is active cases, 1,664 active cases, the third quarter of 2016, where back in 2012 it was 1,218. So there's this increasing trend of more people on AOT. So AOT used to have a lot of controversy around it. It still has some controversy, but not a lot. And I think more people refer to it because it's a less controversial kind of option for those people who meet criteria. Without a court order, they wouldn't comply with treatment, and they might be dangerous to themselves or others. We have some responsibility for supportive housing. Again, supportive housing is a shared responsibility in New York City. There are New York State supported housing programs. There are the Human Resources Administration supportive housing programs, and then there's some within our health department. So we've got in the Bureau of Mental Health more than 7,700 units of supportive housing. That's not just New York 3, which many of you might have heard about, but it goes way back to New York 1 and 2, and other kinds of reinvestment funding that went into supportive housing. So supportive housing is an amazing model of housing for folks who need that extra support. They have to have a mental illness or a substance use disorder or a co-occurring disorder, or be a young adult aging out of foster care at risk of homelessness. And there's been some research on supportive housing and how much savings you can generate, which is on this slide, about $10,000 a year. There was an interim report from a number of years ago that has not quite yet been updated, but some significant savings. But also, when we looked at the programs that are newer supportive housing programs, if somebody's been in a supportive housing program for 7 or less years versus someone who's been in a program more than 7 years, they are more likely to be employed. So that kind of speaks to our newer programs may be better at a recovery focus and helping connect people to things that they want. Thrive NYC has a new supportive housing initiative. So we are no longer New York, New York. So the New York, New York part of New York 3 was New York City, New York State. We're now New York City, 1515. The mayor put his money out for supportive housing. The governor put his money out for supportive housing. They don't like each other, in case anyone follows the news. They just did not get it together to combine efforts. So what we have at a city level is 15,000 new units of housing over 15 years, so 1,000 units a year. Half of them will be congregate facilities where you kind of have a group home-ish environment, and the other half are what we call scattered site facilities, which are just apartments in regular apartment buildings. Those are already starting. So again, 1,000 units a year, and we've already begun. So there will be more supportive housing. There's still not enough. The need for supportive housing way, way, way exceeds what anyone has been budgeted for. The NYC START program, Supportive Transition and Recovery Teams, is our program for young adults with first episode psychosis. What I added on this slide is you can see which Thrive principles it fits under. It's an Act Early Thrive principle and a Closed Treatment Gaps Thrive principle. It really is a way for when somebody has a first episode psychosis and they are hospitalized, we now have a requirement. There is a Board of Health law that says you are required to report that to the health department, kind of like you report a communicable disease. I have a patient with chickenpox. I have a patient with first episode psychosis. You report that to the health department. Our NYC START team gets that information, and then they can evaluate along with the hospital team if they meet criteria to be part of the NYC START program. Again, to meet criteria, you have to be 18 to 30. And then you have to meet, I think I have a slide with this. You have to meet, any number of, I do have a slide with this, schizophrenia type disorders. You have to be a New York City resident. And then you have to want our help. And what our help offers is a care coordination type of service to connect you to care. And we're doing our best to try to connect you to the best care you could get, whether it's an on-track program or one of the other first episode psychosis programs, or whatever it is you are ready for at that point. Let me just see if there's anything here on this slide, just to say the team will stay involved for 3 months. They're using a critical time intervention model. And most of the people accept services, and 3/4 of the people are getting an outpatient appointment or attending a mental health outpatient appointment within 30 days. We'd like it to be higher, but it's not terrible, actually. And hospitals are required to report these folks to us within 24 hours of a hospital knowing that they're there. So we know hospitals are not reporting everybody because we estimated how many people we thought in New York City would meet criteria for first episode psychosis, and we are not even close to that number coming into our team. So I think there's still work to do. The teams will come out to hospitals and talk with hospital staff as many times as needed, and with staff turnover as many times as needed, but it's a pretty critical service. Let me just see if there's anything else here. No. Okay, so I want to just, I think we're pretty close. What we have in our treatment service office is responsible for overseeing our assertive community treatment teams, our ACT teams. What we are doing now, if you remember my slides on NYC SAFE, we have people who we know have mental illness and a history of violence. For those people we know where there's an acute history of violence, if we're assigning them to an ACT team, we're asking the ACT teams to tell us how they're doing. Tell us if you're having any challenges with how they're doing. Tell us if they seem to get lost to care, ideally before they get lost to care. And we're putting our heads together to not lose track of those folks. So our ACT teams have an even harder job than they usually do because we want them to account for these folks. We also have mobile crisis teams in New York City that my treatment office is responsible for. Mobile crisis teams are mobile. They do respond to crises. We know they don't respond fast enough to crises, so they still traditionally have up to 2 days to respond to a crisis, which really can't be a crisis if you could take 2 days. Many of them respond sooner than that. We are working on getting everybody to respond closer to 2 hours. It's a tall order, but we're working on that. Again, to get a mobile crisis team, you call NYC Well. We have a new program for the aging population called PEARLS, Program to Encourage Active and Rewarding Lives for Seniors. And that is a depression-focused in-home treatment model because depression is a problem in the elderly population, and then it interferes with their medical and health conditions. And it's an evidence-based model. We just started this, but there's pretty good success from the research on the PEARLS program, where there's a 50% or greater reduction in depression symptoms or achieving remission with lower hospitalization rates and better quality of life. So we've got teams that are doing screening and going out into the home, and we've got 7 teams across 5 agencies across the boroughs. For the interest of time, I'm okay at the moment? Okay. As the local government unit, we're also responsible, along with the state, to weigh in on the mental health system that has licensed capacity. So if there's increases or decreases or moves of folks in the system, we weigh in on that. We say if we think it's a good or a bad idea, or why don't you think about something else? So that's a role within my bureau as well, where we're looking at applications and we're talking to providers and we're finding out how things are going. So if hospitals want to close inpatient beds, we are part of that decision making. We have rehabilitation services in the Bureau, which are the non-clinical types of services that really get closer to what somebody wants for themselves, really more person-centered. We've got assisted competitive employment programs, respite programs for caregivers, peer bridger programs, and clubhouses, which you can go to during the day. And our single point of access and care coordination office is really responsible for taking in referrals from the community to then connect folks to our ACT, our FACT, our intensive mobile treatment teams. They can also connect folks to non-Medicaid care coordination. So if somebody doesn't have Medicaid, so they therefore might not qualify for a health home or care coordination, we have non-Medicaid care coordination resources we can offer folks. And you do that through what we call SPOA. And this is me. So thank you very much. You're welcome. Oh, good.
Thank you so much for that talk. We're now open for questions. Yes, Dr. Essick.
Hi, Myla, thank you so much.
You're welcome.
Please tell us, you're speaking to many researchers who are just so overwhelmed with the volume of services and oversight you're describing. What are those areas where you wish you had more collaboration with the research community? What are the areas that you are the biggest gaps for you being able to assess the impact of your initiatives?
That's a great question. So what I didn't talk about is through some of the Thrive initiatives, there is a separate evaluative component that's happening sort of broadly at a city level. What are the impact of all these new Thrive initiatives? Which is great, because we do want to know that the new initiatives have a return on investment, are worth putting all of those resources to. But there's lots of existing programs where we don't always have the resources to say, is this the best way to use these dollars? Is this still the best program we should be offering? In this current fiscal and political climate, where should we be focusing our resources? So I don't think there's any one area. I do think the stories I hear are always the most severe stories. I'm a family member of an adult child. They're not going to treatment. They're not getting their care. And again, that's more of a service system issue, but if we could consider what sort of programs should be there to meet the major gaps we have in this city still, that could be useful. So where there are gaps, where we have disparities, where we know we should be targeting and aren't kind of making the way, so tobacco cessation, we know what to do. There are treatments available, and we're not doing it. Why not? Why can't we move that needle? What should we be doing differently? I've heard from people with mental illness who smoke, I'm not going to quit. That's all I've got. And so the mechanisms we use in every other part of helping change behavior may not work the same way for somebody with a tobacco addiction. So do we have to come up with new ways to help people stop smoking when you have mental illness? I don't think anyone's figured that one out yet. That's just one example. I have so many examples. If there really are researchers here who are burning with, I'd love to work with the city on something, I would love to talk, and we can probably match some of those needs.
Dr. Fisher? Yeah.
Wonderful. Just intuitively, a terrific set of options and programs. I'm specifically interested in if you have any sense of sort of yourself, just personally, because there wouldn't be data yet, on the demographics of the psychiatrists who want to work in your treatment system, FACT, ACT, IMT. Where are you getting them from? Because this expansion sounds terrific. All right, yeah.
That's a great question. Psychiatrists are hard to come by. There's a certain group of psychiatry that wants to work in public psychiatry. What we find is it depends on the salaries, right? People are willing to work for less, but not so much less. And I think at least on the ACT teams, traditionally, those rates had not gone up in a long time across the state. Where are we finding them? So I'm just going to say it one more time. These programs are not my programs. We are contracting out with service providers. So they're frequently community-based organizations, frequently nonprofit community-based organizations doing the work. They sometimes tap into their own networks and resources to find people. I think the ACT teams across the city are having a hard time holding on to psychiatrists. Maybe that's an area of research. How do we do that better? Is it just salary, or is there something more? It's a very hard job. It's a very hard job.
Hi, Myla. Betsy Fiddleson. We met before. I run our women's mental health program and also collaborate on one of the Thrive initiatives with OCDV and H&H for domestic violence survivors. I've one comment and one question. I think one comment is that the last question just raised about retention of psychiatrists and probably mental health in general is thinking about burnout, and certainly working with with the DV population, secondary trauma and burnout is a major issue. And Dr. Levin, who's here, does a lot of research in that field. So that's something I'm wondering if the city has thought about as you're expanding this initiative. The second thing is my area of focus is really working primarily with mothers, but on parents with mental health problems. And what initiatives exist to help there are many, many parents who have mental health problems. What initiatives exist to help those parents that might then put them in a better position to be able to raise their children?
So you asked a lot of questions.
Sorry.
I'm going to address, let me address workforce first. What I didn't mention up here, it was on one of my slides, but I said I wasn't going to get to it, but through Thrive, we had a mental health workforce summit that maybe one or two of you were at, where we had one day back in May where we spent the whole day in breakout groups trying to figure out what about this mental health workforce issue. And it wasn't focused solely on psychiatry or any one thing. There were many components to it. So we talked a bit about the pathway into mental health care. So what about earlier interventions? What about schools of social work and nursing to improve the folks that go into those programs so that they ethnically, culturally match New York City and graduate and get licensed at the same rates as someone who might be white, for instance. So we had a work group on that. We had a work group on peers and the peer support network for mental health, substance use, and kids. That also included community health workers. We had a work group on, see if I can remember all of them, one on integrating behavioral health and primary care and what that means from a workforce development perspective. So if you were going to have currently existing residency training programs, are they teaching to have somebody graduate from a program, finish a program, and know what it means to work as a collaborative care psychiatrist, for instance? So there's some psychiatry and nursing work around that. And then there's a work group I'm still most involved in around data. There is zero data that tells us what the actual story is, at least from a New York City perspective, where you could say, oh, yep, we have an aging psychiatry population in New York City, and indeed, if we don't do something back at this end, we'll have this sort of gap later. There is no story like that. There are national organizations, the American Academy of Child and Adolescent, ACAP has done some stuff. Some folks have done it at sort of a national level, but that doesn't help us figure out what to do here, particularly since we know New York City has most of the psychiatrists. They're not working in public health. They're not taking public insurance. That we know, but we don't know it again to say what to do about it. So I think there are some real things we are still working on, we know we have to work on, and if folks want to be involved in workforce-related issues, there'll be plenty of opportunity. So I'm happy to talk some more about that, because it is a problem. It's a major problem, and even if we do more on collaborative care, working with behavioral health and primary care, you need a behavioral health person to either take your referrals who are higher end, so you have to build a system to meet the need. You also asked about the parent mental health. I think, I have a few answers, but I think parental mental health is a gap. What we do, unless they're very young kids, parents who have mental health issues where we know if they don't get treatment, there are major implications to their kids and their kids' mental health. We don't, I think, pay enough attention to that or have some fantastic models for that just in general, like across the age span of a parent's life with their kids. There are things we have for parents of young kids. We have an early childhood mental health initiative at the bureau, not in my bureau, in our Children, Youth, and Families Bureau, where we are offering intensive treatment services for parents and kids up to age 5. So early childhood mental health services, more services than we've ever had before. And there's a model we're promoting called Circle of Security, which is a parent coaching kind of model for parents also of kids up through age 5, where it's 8 or so sessions of a group of other parents that's facilitated and has been pretty successful in just helping parents understand the attachment with their own kids. So it's a very attachment-based model. It doesn't, if your kid has major behavior problems, it may not meet your needs, but it's a step in the right direction. But I do think we have some gaps we say, well, we've got adult mental health services for parents, but how many adult mental health providers are even asking about what can I help you with as a parent? So I think we have to be more creative about that. I agree that that's a big gap.
Yeah, I just want to comment on the mental health summit, since I did participate in that and was part of the integrated care group. And each group was tasked by the end of the day to come up with specific action items. And our group was predominantly people working at the section of behavioral health care, although there were some people from primary care that were present. And one of the action items was really bringing primary care and behavioral health care trainers together to think about how we train in these silos, and then our trainees work in these silos. So how do we bring these trainees together? But the wellness and the burnout was one of the action items our committee came up with, that we said it's not just about training in these systems, but sustaining them, and we really need to take a close look at that. So that is really important.
Actually, then before the next question, I want to add one other point on that. Greater New York Hospital Association and Chicanes, which is the Association for Community Health Agencies, does a survey every year, and they have some questions around retention and burnout, and we are, for the data work group that's part of the summit, we're waiting to get the data from them so we can see some of that information. And then again, let's tell this, what is the story, right? Anecdotally, oh, people leave, or they go for higher jobs, or they've had, but what's the actual story?
Dr. Dixon?
Way in the back. Yep.
I want to just say a couple things. One is that thank you for this presentation, and also, this amount of work is heroic. This is even just the tip of the iceberg for the entire initiative. And excuse me, at the Center for Practice Innovations in my division, we've had the opportunity to work with the city on some of these projects, and the ambition is incredible, and the productivity as well. That having been said, one of the things I worry about, and I think I suspect you as well, is that there's kind of two things happening at the same time. So we're having a major change in the whole system of care for individuals who are insured by Medicaid, and the introduction of health homes, and it just goes on and on and on. And I worry, so you didn't touch on that, or how these set of initiatives is kind of interfacing with, I sort of like, is this, this sort of the tectonic plates are shifting, and how is Thrive New York City kind of dealing with that? And then just one other question to layer on to that is, this is an initiative of the de Blasio administration. And so one of the things that I know that a lot of us worry about is, what is the longevity? How vulnerable are these programs? And so what, so is there sort of a certain amount of time pressure to get things, done?
So definite time pressure to get things done, because this particular administration, I think, wants to show results so that they can get reelected, I suppose. And that will help from a sustainability perspective. But yes, there is incredible time pressure with all those 54 initiatives. And if you're involved in any one of them, you probably feel it to some degree, because we call you all the time and ask about your outcomes. And I knew I wasn't touching on all of the policy and fiscal changes that are happening when I put this together, not intentionally. I was trying to figure out how to frame it all up. So I'm really glad you asked the question, because the city's health department is very involved in the Regional Planning Consortium, which is our local way of keeping our fingers involved in the Medicaid redesign. And we have regular meetings with managed care plans, with providers, with PPSs, with consumers, as a way to stay involved with what's happening from a Medicaid redesign perspective. What is happening with the health homes? Where are we with the home and community-based services? What's the impact of that on New York City? And that does So that's happening at a New York City level. So those RPC meetings are not happening in my bureau. They're happening in a sister bureau. But me and my staff attend all of those meetings, so we're very aware. And it impacts us in many other ways. That last slide where I talked about the rehabilitation services, a lot of the new HARP HCBS services are in the rehabilitation category. Not all of them, but a number of them are. So we imagine continuing to have some involvement in that. Our providers were the ones we said, please make sure you're a designated provider so that you have a revenue stream in the future if and when the state dollars decrease over time. We are very concerned about that and are constantly trying to figure out what that means for the work we do, for what we want to put forward, for our planning efforts. But you also asked an interesting question about how like the Thrive projects relate to where we're going with all these other initiatives and incentives. So, right, so the incentives are changing from a New York State Medicaid perspective, right? We're moving to value-based payment. We're moving to integrated behavioral health and primary care. So we are trying to align where we can. So Mental Health Service Corps, where we're putting clinicians in primary care settings, let's align it with the PPSs who are getting funding, who could potentially pay out for value-based payment or figure out how to have the connection to value-based payments. So we're trying to do it where there are those natural opportunities. So Mental Health Service Corps is certainly one of them. But those conversations happen, and I didn't frame it up for this conversation, but it's really critical because the funding, the policy, the Medicaid, all of that is changing at the same time that the city put lots of money into these resources. Our Office of Management and Budget is constantly asking us, where are you getting revenue for all of these programs? And in many cases, we're not. So those new intensive mobile treatment teams I talked about, it's about $1 million a team. We are not looking for revenue for that right now. It doesn't fit into, we don't want it to be an ACT team because then it's going to sort of hem it into something. It doesn't fit into a billable model we have. We're not asking people for their Medicaid cards. But if I were heading the Office of Management and Budget, I'd say, well, that's not a sustainable program. And so we better then find some really good outcomes that show savings to the city somewhere else. And so those are the things that we talk about. There's a question in the back.
Dr. Heiler.
Hi. I have a question about what you do with data in terms of big data and how the data is managed and how do you weigh the data with privacy issues and things. Now, if we have a 20% prevalence rate of serious chronic mental illness, let's say it's about 1.6 million out of about 8 million individuals who might have a unique number. Is there currently a database that keeps track of or can keep track, or are we doomed to have a separate database for ACT teams, for assertive community action teams, for AOT? And just as an example of weighing the needs of the community versus the privacy needs, I'm trying to figure out why it's necessary for the hospitals to have to report in terms of NYC safe to anyone about having someone. Can someone just access a database of a diagnosis and have that data? Why do you have to rely on, and obviously that weighs against privacy needs and HIPAA requirements and high tech, but on the other hand, the insurance companies have access to all this information for billing purposes. So they could get the data so they could get paid, but are you saying that we can't get the data to keep the population safe? And if that's the case, who's in charge of this?
I think that question is a little bit above my pay grade. There is no centralized data repository yet. In fact, there's a meeting that I'm not at right now back at my office on the RIOs, the Regional Health Information Organizations, where there are some, like the Bronx has a RIO, where there's some of that across health system networks. There is no one body that's keeping all of your patients' medical records. That doesn't exist in this country. I don't think we'd ever get something like that. There are a number of things. You actually mentioned insurance companies. What the insurance companies tell us is they get the data when it's a claim. Claim's too late if you want to intervene. So that's one caveat to insurance information. We have some access to Medicaid data. So if somebody's on Medicaid, we can do some summary information. We at the health department have no rights to look at individual Medicaid data. That is not something that we can do. So we are reliant on people telling us stuff. The State Office of Mental Health has a CARES database, which the providers have to enter into on the people that they're serving, for instance, on an ACT team, but they only have to enter once every 12 months or 6 months. So again, it's not usable. If you needed to use something to intervene, it's not going to help. From that perspective. So there are thoughts to this, but I don't think any one answer. We've got psyches from I don't know if we have any folks here from psyches. Psyches as a way to pull the Medicaid data into some usable formats, but again, so more for a clinical intervention if you're the clinician, or for where they might have been in treatment in the past, or if they have been on AOT or have a health home, like it's useful for some things, but again, that's for the population who are on Medicaid. So I don't think anyone's talking about one centralized system for everybody, and if if that's even a feasible option. We've got more than one kind of EHR out there that don't even, necessarily talk with each other. Our primary care folks at the health department, there's a group called the Primary Care Information Project, PCIP. They have data agreements with a few thousand primary care providers through electronic health records and can pull summary reports. So they can say through the EHR that they've helped set up with a primary care site and have given some quality improvement and other sorts of interventions to get to meaningful use, and other places where the government's helping to promote moving in that direction. They have some access to summary level information. They can tell how many practices are screening certain rates for depression, for instance, with PHQ-9. You can say, across these 30 practices, they have a 59% screening rate. We can get that kind of information at a practice level if they're in this primary care information project. Again, only on one indicator that's relevant to mental health, though. I don't know if I answered your question, but.
Who makes the decision about who has access to data?
It depends on the data, right? Tom, do you want to say? I mean, it really depends on the data. I see Tom Smith, who can maybe weigh in on that. There.
You talk as if there's a database somewhere, right? There are a lot, yes. There's no single. So you're referring. Is there a registry somewhere where people with certain kind of diagnoses or category circumstances could be information could be kept? No, I mean the shortest answer is that's un-American, right? That's not how our healthcare system is structured with multiple different providers, payers. It's not how we think about in terms of individuals' rights, confidentiality, a lot of concerns about stigma, misuse of such information, right? Look what's going on with Trump right now, right? So no, no. There are, however, many registries. We are definitely in the age of information technology, which means there's a lot of data out there that can be used to both help individuals get better health care and help providers and oversight agencies do their jobs. And that's clear. You can't deny that. So there's all sorts of efforts. Myla mentioned RIOs, right, to allow for sharing of information at the individual level in real time to help people get better care. There is a push for registries, right? The American Psychiatric Association has committed to building a registry for depression screening to support scaling up collaborative care models nationwide. So there are registries out there. OMH has a CARES registry. So there's all sorts of databases and information out there, and there's incremental efforts to use it to help to make things better for people providers and oversight agencies. But you're never going to see any kind of blanket, okay, let's create this kind of registry for mental illness. You won't see that, or for schizophrenia, as you mentioned.
Thank you. Unfortunately, we're out of time, but I want to thank you again for a wonderful talk, and please join us for lunch up in the multipurpose room.
Thank you. Thanks very much.